And yeah, just for the people who weren't here when I said earlier, I'm not going to be able to see the chat or the video screens as I'm presenting, just with how my screens are set up in this room. So if anybody has any questions, feel free to just shout them out or put them in the chat, and maybe Rita, if something comes up in the chat, you would be willing to interrupt me and let me know something's there. Otherwise, I'll try and stop frequently for questions, and there will also be a question period at the end. I'm just going to share my screen here, and just please let me know if you guys are able to see it. Is that coming up okay?
Looks good.
I can see it.
Perfect. Okay, awesome. So I'm just going to jump right in. So just as a warning, this presentation will discuss death and the dying process. So if at any point anybody feels uncomfortable discussing this topic, please feel free just to leave the room and then step back in when you feel comfortable. As a general overview of what I'm going to be presenting, I'm going to be going over what is palliative care. I'm going to touch quickly on advanced care planning. I know that a couple of other groups have presented on advanced care planning for the Family Council. I think NIDAS probably maybe. They do advanced care planning pretty often, and it's a common topic, so I'm not going to spend too much time on it. I'm going to be going over some indicators of declining health, some palliative symptom management, and that is what you might see happen as your loved one is declining, managing things like pain, nausea, breathlessness, things like that. We're going to go over some of the common changes you may see at end of life, and then at the end there'll be a question period. I would also like to mention that each facility likely has their own guidelines and protocols related to palliative care in general. They're all going to have their own kind of guidelines and ways to do assessments and symptom management, and their own pathway for escalation if there are concerns. So this presentation is aimed to give a very general overview of kind of palliative care and those symptoms. But if you guys have really specific concerns, especially if it's related to the care your loved one is receiving, I would suggest to bring those to the manager at your facility, as I might not be able to speak to each facility's exact process, if that makes sense. I've kind of phrased this presentation as well, kind of in light of a loved one who has a resident, a loved one of a resident in long-term care, and the things you might see and how you might support your loved one as they go through palliation and long-term care. So that's kind of the lens in which I kind of framed the presentation. So who am I and what team am I a part of? Like I said, I am part of the Northern Health Palliative Care Consultation team. We are a small team that consists of a team lead. We have a lovely admin assistant. We have a physician lead, a few palliative physicians on call, nurse consultants, which is my role, and then we have a regional pharmacy lead as well. We are a resource to clinicians providing palliative care in all care settings, and we help and we hope to increase overall knowledge and clinical skill around the management and care of patients receiving palliative care. It's important to note that we're not a direct resource to families, rather we're a specialist team that are contacted by clinicians who need assistance with complex cases. However, if you would like our involvement, it is possible to ask your family physician, or the nurses in your facility if they would like to consult us, and then nursing staff and physicians are free to ask us questions if they need assistance, and they can bring us in on those more complex cases as needed. But that's kind of my role on my team. So what, someone said the word palliative, what does this mean? And then what comes to mind when you hear the word palliative? Is anybody brave enough to say what comes to their mind when they hear the word palliative, or put it in the chat or something?
It brings to mind like end of life care.
Yeah, end of life care, absolutely.
End of life.
End of life, yeah. Perfect. Yeah, so end of life is definitely the most common answer that I get when I ask that question, and that is absolutely a part of palliative care. Some of the other common answers that I get would be like comfort care only, focusing on quality of life, things like that. Those are kind of common conceptions of palliative care. Just going back to my slides here. Perfect. So according to the World Health Organization, palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So what I would like to briefly touch on is that palliative care does definitely include end-of-life care, but it is not only end-of-life care. And we like to touch on what we consider a palliative approach to care, as well as end-of-life care. So I've made this little kind of diagram here to kind of try and explain the difference between the kind of different phrases that you might hear. This is also hopefully to mitigate some concerns or fears if you hear the word palliative used in reference to your loved one. And you start thinking that it's end of life and we're not doing anything to cure or to treat, and there's kind of nothing else that we can do. That's a common misconception when the word palliative is used. However, the word palliative and a palliative approach to care should be utilized as early as diagnosis of a life-limiting illness, or as early as diagnosis of dementia, or when we start seeing these kind of general indicators of decline in old age or in frailty and things like that. A palliative approach can be used much sooner than end-of-life care. So as you guys can see here, kind of in this bigger circle, we have the palliative approach to care. And this is the largest circle, and it kind of encompasses all three parts. So when a patient is first diagnosed with a serious or life-limiting illness, including frailty or dementia, a palliative approach can be initiated. And some of the steps in this process would involve advanced care planning to learn about the patient's healthcare wishes while they are still capable, managing symptoms to help relieve suffering, offering emotional and spiritual supports, and providing education and information regarding their disease process. It should be noted that all of this can be done alongside curative treatments, not just instead or replacing curative treatments. Chemotherapy, radiation, surgery, hospital admissions, all of these things can still be happening while we are considering this palliative approach to care. The main takeaway from a palliative approach to care is around ensuring that we are easing suffering through managing symptoms and improving our communication to ultimately improve quality of life. So giving as much information as we can, recording those advanced care plans, finding out what's important to the patient and their loved ones, those are all a part of a palliative approach to care. And although a palliative approach to care should begin at diagnosis, what is most commonly referred to as palliative care, so that middle circle there, is often initiated in the final months to year of life. This is likely when you'll start hearing the word palliative be thrown out kind of more, especially in kind of long-term care settings as well as hospital settings. They might almost use palliative as more of a designation than an approach to care. So you might be hearing the word a little bit more. And this is when people begin to kind of decline. Curative treatments are no longer effective, and their symptoms like pain, nausea, shortness of breath might be increasing in severity. This stage also involves more active symptom management, so we're going to be doing more of that symptom control, and we're going to be putting in increased supports for the patient and their caregivers as best as we can. And this is a really good time to review those goals of care and those wishes that were spoken about earlier on in the process, so we can make sure that we're still doing the best that we can in supporting the patient and what they want as they are declining and possibly nearing end of life. And then that smaller circle there, we have end of life care, and this is going to be the final days to weeks of life. In this stage, the focus has shifted entirely from curative treatment to comfort care. This stage involves acute symptom management and support of a comfortable and dignified death, whatever that means for the patient and their family, and then it extends into grief and bereavement supports for families and loved ones as well. This is kind of another way to explain it. This is a model that Northern Health has adopted called the bow tie model. So on one end, on the left-hand side there, you have disease management. On the right-hand side, you have palliative care. And you can see that they're kind of two overlapping triangles with the overlap in the middle there. On the left-hand side, when a patient is first diagnosed with life-limiting illness, or perhaps they've just reached old age and things are starting to kind of slow down, and they're kind of known to be nearing end of life. That's when we're in what we still call the disease management phase. So this is going to be things like initiating medications, chemotherapies for cancer, radiation, surgery. We're still doing all of the things to manage the disease as best as we can. And then the palliative care triangle is just the very, very tip. You can kind of see in the middle there. So it's not as big of a piece of the puzzle in the beginning. And then as the patient progresses through their illness, maybe they're getting a little bit sicker, maybe the medications aren't working as well as they used to, the palliative care triangle gets bigger and bigger, which is that middle section, which is pain and symptom management, where the disease management and palliative care are working together to help control pain and symptoms during the process. And then as we move even further along and disease management is no longer effective, maybe they're not a candidate for chemotherapy anymore, the medications might have stopped working and we're getting lots and lots of symptoms, the patient is declining, and we're kind of nearing end of life, then you can kind of see that the disease management triangle kind of shrinks down to nothing and the palliative care triangle kind of takes over. And that's when we get to more end of life care. Does anybody have any questions about kind of the palliative approach to care versus end of life care and those kind of topics?
Can we go back one slide?
Yeah, absolutely. Give me 1 second here. There we are.
So when we went into Dunroven, it was because we needed help, but they started treating him like it was an end-of-life disease, which dementia is, but we're into our 3rd year. So do we get a choice if we want to accept this care, or we want to still stay with the normal care people in the community get?
So I like to emphasize again that palliative care should be given alongside kind of what you're saying is the normal disease management as best as we can until it's decided by the patient and family that that is no longer what you are wanting. Ultimately, it's up, especially if the patient has an illness like dementia, they can no longer make decisions for themselves and they have somebody else making those decisions. It is up to that person who is now the decision maker to kind of guide the care plan for that patient ultimately. We do like, again, to try and initiate the palliative approach early because we know that dementia is going to be a life-limiting disease. And the more that we have these conversations around end of life and kind of take that approach, hopefully the better quality of life for the patient and the more informed the family can be as things kind of progress. But ultimately the care decision should be up to the decision maker.
Great, thank you.
Yeah. Did that kind of answer your question?
Yes, thank you.
Yeah. One of the principles of palliative care is supporting the patient's dignity and autonomy and their kind of wants and wishes. And a lot of the times we get kind of pulled into these cases where it's almost as if they want us to like kind of convince people to go a certain way, but that's really not what we're here for. We're here to support the patient and the family and what their wishes are. So we try and do that as best as we can. Hopefully that makes sense.
Good.
Sorry, it takes a couple of seconds for me to get back to my slides every time. There we go.
So Amy.
Yeah.
I'm just wondering, you know, for the decision making for family, for a patient that has dementia, and say the daughter does not live in the same town, would said daughter be given information regarding her parent all through this stage, or how would that work exactly?
So in an ideal world, any sort of care decisions that need to be made, it might not be the day-to-day things, but any kind of major decisions. If the patient no longer has capacity, then the person who has been granted the decision-making power should be kept in the loop for sure. Who has that power can be a little bit tricky sometimes because if the patient has not created what's called an advance directive, or sorry, not an advance directive, a representation agreement, naming who they want their decision maker to be, then it goes through like a hierarchy tree. Like that's written out in law, and it goes like, I don't know it off the top of my head, unfortunately, but it's something like spouse and then children and then siblings, and it kind of goes down a list. And sometimes the people who are maybe most involved in care aren't necessarily the TSDM, the substitute decision maker, for that hierarchy list. So sometimes you get a little bit of back and forth with that. But if that person has known decision-making kind of power for that patient, then ideally, and again, in an ideal world, they would be kept in the loop and informed of those kind of major treatment decisions and be able to have that conversation with the physicians and nurses as needed. Does this always happen? Maybe not, but in an ideal world, that would be what would happen, yeah. Did that answer your question, Lisa?
No, I wanted us to. Oh, you want to?
Yeah, it did answer my question, because it's quite difficult when, one doesn't live in the same town.
Yeah.
And, my mother does not have the ability to make decisions. So it does fall on me. I have been given the power to make decisions, but I'm also currently in the middle of becoming applying for a committeeship for her. So just to make everything legal, the hospital does know that I am the one to make the decisions for her.
Mm-hmm.
And it's allowing for me to think that, the dementia sort of shortens one's life. So I do have to look into this palliative care and palliative approach. But this information is it's so important, and I really, really appreciate your help in letting everyone understand what is entailed in palliative care.
Thank you so much. I'm hoping that I'm able to answer most of the questions that I can that people have. I know we don't have a super long amount of time together, but like I said, feel free to ask any questions and I'll just answer them to the best of my ability as we're kind of moving forward here. But thank you so much. So like I said, yeah, I just wanted to touch super briefly on advanced care planning. When patients are early on in their illness and they still have decision-making capacity, advanced care planning is a really important component of the palliative care approach because it lets us find out what is the most important to our loved ones or for yourself if you're the one making the plan. And it allows us to record them in a way that they can be followed by the substitute decision makers, as well as the healthcare team as needed. So advanced care planning involves having open and honest conversations with your loved ones about their values and wishes for end-of-life care. And it can provide guidance for future healthcare decisions if that patient becomes incapable. This can decrease the burden on the substitute decision makers and caregivers because they don't have to guess on what their wishes might be. Their wishes are already known. And then ideally, these would be communicated to the healthcare team so that everybody's on the same page. This booklet that is pictured here, this is called My Voice. It's in a bright, bright yellow booklet, very handy little tool. This is put out by the government of British Columbia. and it is an advanced care planning guidebook. So it'll take you through kind of the advanced care planning process, and then it also has copies of those more kind of legal documents like advanced directives and representation agreements, if you are needing to fill those out, and then it kind of gives a step-by-step on how to fill everything out properly. It's a really awesome resource. A lot of the care facilities should have them kicking around, and if they don't, it's available online as a printable PDF, as well as advancedcareplanning.ca has a bunch of online resources. They have an online fillable guidebook. They have a similar guidebook that can be printed. Even if you just look up advanced care planning, you can find a ton of online resources. So I always just like to make a little plug for advanced care planning because it's something I'm really passionate about. I think it's super, super important. And there's been so many times where I've come in to a palliative case where the family is just wishing that they had this advanced care plan and that they knew what their loved one wanted before, they lost their ability to speak, or, they lost their ability to make decisions, things like that. So I always like to do a little plug for advanced care planning in my presentations.
I agree with you, Amy. So we have an advanced care planning presentation also at Gateway, and I encourage everybody to have this done. Don't wait until you're sick. Do it now, put it on your fridge. So if you and your spouse are in an accident, somebody knows where those papers are and they can speak for you.
Yeah, super important piece. I agree. Okay, so moving on a little bit, switching gears a little bit. I find that a lot of the times, advanced care planning kind of topics like that kind of are what are presented on the most, but not a lot of, where most of my questions come from members of family councils or even just family members of patients that I'm working with, are kind of like, what are the signs to look for? What can I expect? What kind of medications are used for different symptoms? Just a kind of a general, like, what's going on is more so the questions that I get. So with this presentation, I tried to do more of like a practical, what you might see as your loved one is nearing end of life, and kind of what the general approach is as a healthcare provider to a more palliative approach and to palliative care. So this section, I'm going to be going over some general indicators of decline and what it might look like as people may near end of life, and kind of what to look for, as the indicators of decline. So some of the more common indicators of decline that you might see that might prompt you or prompt the care team to start thinking about increasing more palliative supports would be worsening weakness. So this would be like suddenly they can't walk to the washroom without needing to sit down. Or, they're spending a lot more time in bed than they used to. Things like that. Increasing fatigue, maybe they start needing a midday nap, maybe they start needing 2 midday naps. They're complaining of feeling tired a lot, things like that. A weight loss could be an indicator of decline. Decreased food and fluid intake, saying that they're not feeling hungry anymore, that they feel full all of the time. Having increased dependence on the care team, so needing help, maybe they just need help with showers to begin with, but then later on they need help getting dressed and doing kind of those more daily tasks like brushing their teeth or things like that. They have this increased dependence on the people who are caring for them. They may have persistent symptoms despite optimal medical management. So this means that they have symptoms of whatever illness they may have, whether that may be from cancer or from congestive heart failure or from COPD, whatever their life-limiting illness may be. They might still have these symptoms and they may seem to be getting worse despite the fact that we are giving them the best medical treatment that we can. They may still have fluid overload even though we're giving them diuretics. They may still have difficulty breathing even though they're using their puffers every day. The things that used to work might not be working as well anymore. And then they might have some increased cognitive impairment. They may be drowsy more often, and kind of, I would say, nearer to end of life. They may even have like a delirium where they're quite confused and might have a sudden onset, or their cognition might fluctuate throughout the day. They may seem really bright at some points in the day, and then they might seem very confused or drowsy at other points in the day. And those are all kind of just very general indicators of a decline. And for symptom management, so while the dying process looks different for each patient, and not even the dying process, but even just having a decline in health, there are some common symptoms that might occur at the end of life. Just because they're common does not mean that they're normal, and we like to, again, prioritize quality of life and comfort for these patients. So we do like to treat these symptoms as they come up, even if they are common or even expected symptoms for the patient's illness. And these could include pain, nausea, shortness of breath, or delirium, or just confusion. The likelihood of these symptoms might increase depending on the disease process. For example, a patient with COPD is much more likely to experience shortness of breath than any other symptom. And then there are medications that may be recommended by your care team to help ease these symptoms. So I'm going to start off with pain. And again, pain is a common end-of-life symptom, but it does not mean that it's always a normal end-of-life symptom. And we like to keep patients as comfortable as we can and to increase their quality of life as much as we can. So these are some of the non-pharmacological or non-medication interventions that we can bring in when somebody is having pain. So we can bring in, and again, these are going to be different for every site. Some of these things you guys can help with as the caregivers or as family members. Other things may need equipment or other people involved. But yeah, these are just the non-medication kind of interventions that we can use. So there's massage therapy, physiotherapy, different positioning, and then hot and cold packs. We could also try relaxation therapies, meditation, or cognitive therapy if the pain has more of a psychological aspect. A lot of the times, anxiety and fear can really feed into pain sensations. So sometimes also addressing pain from a psychological approach can be really helpful. We can have spiritual and cultural practices, support groups, and counseling, again, for more of that kind of psychological, spiritual, and emotional health as well. And then sometimes we have interventions that may require some extra equipment. So that could be like a TENS machines or acupuncture. If it's within the patient's goals of care, like if they're willing to be transferred and willing to go through further treatment, we can also consider things like palliative radiation for certain cancers or palliative surgeries, sometimes taking out sections of tumor or like creating an ostomy because we're having a lot of abdominal pain and constipation, things like that. Can help to relieve pain overall. But again, it needs to be considered if that's what the patient is wanting, and if going through those treatments will overall increase that patient's quality of life in kind of a meaningful way. One of the more common medications that you will see when treating pain are opioids. Opioids are very common in palliative care. But how we use them is very specific and very intentional. They are given and especially started at doses that are aiming to provide comfort, not to hasten the death. That is a common misconception that like once you're started on opioids, you know, your death is imminent, or they're just wanting to sedate me until I die. Very common misconceptions. But it's just important to note that the way that we start the opioid dosing and the way that they are used are very much for comfort and not to hasten death. If we're hastening death, we're doing it wrong. So
can we go back one slide?
To the camera.
yeah,
There's the camera. That's where she can see.
Oh, can we go back one slide?
what more?
So if our facility has none of this psychological, physical stuff, will Northern Health allow us to bring in our own people to do that?
I would think so. Again, it might be site specific. unfortunately. I'm not sure. But I've definitely seen people be brought in those kind of situations. I've even seen like personal, I used to work in the hospital, not a long-term care home, but I know that in hospital I've seen like private care aides be brought in. I have seen like pastors and things like that be brought in for some like psychological or spiritual counseling. And then some areas, yeah, in the hospital in Prince George, they have like Indigenous liaisons. And those positions have been brought in for the spiritual health as well. Again, I don't really want to say an absolute yes or no because it might be site specific, but in my experience, I've seen people be brought in.
Okay, thank you.
Yeah. Oh yes, okay. So opioids in palliative care are indicated for both pain and shortness of breath near end of life, which is not a commonly known thing. A lot of the times opioids are ordered for shortness of breath and the family might have a lot of questions like, well, where is their pain? They never said they were in pain before. Why are we starting them on this medication? But just know that it can be used for pain or shortness of breath. It's again often initiated at very low doses to assess tolerance, and then unfortunately it also comes with some common side effects such as nausea and constipation. So if your loved one is initiated on an opioid, they will likely be initiated on a laxative and an anti-nausea medication as well. The nausea and any drowsiness that might come with opioids are symptoms that most likely pass within 3 to 5 days. So we're not expecting drowsiness or nausea to stick around forever. However, the constipation that is caused by opioids is kind of a long-term symptom. As long as you're taking the opioids, you can kind of expect to have some constipation. So they will likely be on laxatives for the duration of the time that they're receiving opioids. Some of the common fears and misconceptions surrounding opioids that I have heard in my practice quite a bit. So there's the fear of addiction. Again, we're starting these doses very, very low. Our motto is start low, start slow. In an ideal world. So the doses that we are giving are not likely to cause addiction, and also they're given to treat a symptom. They're not just given because they're end of life. If we're prescribing an opioid, it'll be for pain or for shortness of breath. So we're giving it with a purpose. There's also quite a lot of misconception between addiction and tolerance. As our body gets used to being given opioids, we develop what is called a tolerance. And that means that our body is kind of getting used to the dose that we're being given. And as our disease is getting worse, perhaps our pain is getting worse, and our body is getting tolerant to the opioids that we're receiving, it's not uncommon at all to have to increase the dose to better control the pain. And a lot of the times that can be kind of misconstrued as addiction. Oh, you're needing more and more and more and more. But in reality, again, as the pain gets worse and as your body gets used to the dose, increasing the opioid dose is kind of to be expected and shouldn't be, unless there are other kind of factors involved, that shouldn't necessarily be a flag for addiction. Like I started on earlier, being started on an opioid means limited life expectancy. Again, that is not the case. We are aiming to give the lowest dose possible to control the pain. And we are not giving it in a way that is to be purposely sedating or hastening for end of life. Opioids are very sedating and cause zombie-like states of confusion. When we are starting an opioid or when we increase an opioid dose, drowsiness is an expected side effect in those kind of first 3 to 5 days. And especially if we're starting them on a patient that is elderly or frail or quite far along in their disease process, they may be a bit more drowsy or a bit more sedated than a 25-year-old with no health problems at all. But what we are looking for is for that kind of sedation and that drowsiness to pass within 3 to 5 days. And if it doesn't pass, if it doesn't start to clear up, and we can't really find a reason why, like if they're not, actively passing or having another reason for the drowsiness, then we would look at kind of adjusting the dosage to try and decrease that drowsiness and that sedation as much as possible. Fear the opioid won't be effective as pain worsens. The great thing about opioids and why we tend to use opioids is because they don't have what we call a ceiling effect. So medications like Tylenol or Advil, things like that, they have a total daily dose and you're not supposed to go above that dose, right? For Tylenol, you can't go above 4 grams of Tylenol in a day, or you risk kind of damage to your liver and things like that. But medications such as morphine or hydromorphone, they don't have that ceiling effect. So as the pain increases or as your body gets tolerant to the opioid, we're able to increase that dosage of the opioid to match that, to hopefully better control the pain. Whereas with other pain medications, we don't necessarily have the freedom to do that. Being allergic, another common fear and misconception. A lot of patients will have allergies to morphine or hydromorphone or things like that on their chart, and they may be very hesitant to take them because of that. However, a true allergy to an opioid is actually quite rare. A lot of the times people are reporting allergic reactions because they get itchy. And unfortunately, that is a common side effect of opioids. And of course, we do want to be aware of that and take that into account when we're prescribing it. But if you have itchiness with morphine, you may not have itchiness with hydromorphone. So if itchy is kind of the only concern, or nausea, that's another common one. Again, kind of another common side effect with opioids. Again, something to definitely be aware of. But if we're having pain, it's still worth trying these opioids unless it's been recorded that you have a true allergy like anaphylaxis. It's still worth trying these medications because maybe a different formulation or a different dose will be effective for your pain, and we are able to either mitigate or manage those side effects for you at the same time. If it's nausea, we can give antiemetics. Again, that's hopefully passing within a couple of days. And if it's itchiness, we can try a different opioid or a different dose and see how we go. And then same thing for fear of intolerable side effects. Drowsiness and nausea will hopefully clear. Constipation we can manage with laxatives. If we start an opioid and we do find like truly intolerable side effects that we cannot manage, then we will absolutely look at a different care plan. But for the most part, we can manage the side effects that are associated with opioids. Sorry, that was a super long spiel on on this slide. But I get a lot of questions around opioids, so I like to kind of answer them as best as I can. Alongside opioids, there are other medications that we can give to help with pain, and these are called adjuvants. Fancy word for other medications. These could include NSAIDs, so like Advil or naproxen, Tylenol, corticosteroids, muscle relaxants. Some antidepressants and some anticonvulsants have pain relieving properties, especially if the pain is neuropathic pain or nerve pain. A lot of the times opioids are not the most effective medication in managing that type of pain. So we bring on other medications like amitriptyline or gabapentin. Those are kind of the most common ones, to see if we can manage that neuropathic pain via a different route than opioids. Does anybody have any questions about pain or opioids before I move on? That was a super long spiel. Okay, not seeing any. I'm going to move on. So moving on to nausea. So these are some of the non-medication interventions that we can use for patients with nausea. And in more severe symptoms, these interventions should be used alongside medications. So we can provide oral care, making sure that we're brushing teeth really well, and using mouth swabs as needed, just to get rid of any of the gunk in the mouth that might trigger nausea and just keep things healthy in there. Preventing constipation, so giving laxatives as needed and monitoring bowel movements to make sure that we have a regular schedule, also very important. Keeping fresh air in the room and eliminating strong odors, increasing oral intake in a progressive fashion after somebody has vomited, or there's like a kind of a concern with the GI tract. So moving from things like ice chips to clear fluids to full fluids to solid food, instead of just handing somebody a sandwich right away, might not be the best after somebody's just vomited everywhere. You know how it is. Aromatherapy, if your site allows, considering acupuncture, acupressure wristbands, and considering hydration. When considering hydration, hydration can be given through sub-Q, so like through the skin or IV. It's a bit of a hot topic in palliative care because there's really only an overall benefit to hydration if the patient's functional status is still kind of high and their body is still able to process that hydration properly. So it's really important to assess for fluid overload and really important to weigh the pros and cons of giving hydration before we give it, because if the patient is end of life, you know, and hydration is not going to actually give them a benefit moving forward, if their body is not able to process it properly and it won't provide them a higher quality of life, then oftentimes it is best not to give the hydration sub-Q or through an IV and just to focus on what they can take in orally. Because again, that risk of fluid overload and just kind of causing more symptoms is quite high as patients near end of life.
Wait.
Yep.
How would you know about symptom overload?
About like fluid overload?
Yeah. So
Yeah.
how do you know if you're drinking too much? What?
Yeah, so as patients near end of life, and I'm sorry, I'm so used to calling them patients. That's just kind of how I generally refer. But if somebody is fluid overloaded, especially at end of life, that's when we'll start to see kind of like puffy skin. They might be holding the water in their legs, especially, or in their arms, or even in their kind of like abdominal trunk. They may start feeling kind of puffy and tense, and that just means that the fluid isn't being processed by the body properly, and it's kind of going where it's not supposed to. Another thing that we look for is decreased urine output. So if they're, you know, already incontinent or end of life and they're going to the washroom via a brief, we'll notice that we're not changing as many briefs as we used to. They're not peeing as much. Or if they have a catheter, we're not seeing as much output. Those are all kind of signs that the fluid is kind of going in the wrong spot. And then when it comes to like weighing the pros and cons for hydration itself, it's just taking into account kind of the full picture of the patient. You know, if they are really nearing end of life, their body is not going to be able to process that fluid that we're giving them as well as you and I can process that fluid. So if we give them fluid, like via an IV bag or something like that, because we're worried they're not drinking enough, we could actually cause that fluid overload where that fluid's going where it's not supposed to go and it's not being processed out of the body properly. And that's something that we really want to avoid. In some cases, you know, if all of the context is looked at, the entire kind of the big picture of the patient is looked at. Sometimes, you know, we can say, hey, let's give hydration a try and see if things perk up or things get better, and just keep a really close eye on the urine output and the skin puffiness and things like that. But sometimes the care team will look at the patient and say, you know what, I don't think it's actually appropriate to give IV hydration at this time, even if the patient isn't eating and drinking very much, because their body just isn't able to process it in the same way. Does that kind of answer your question?
Yes.
Yeah, okay. When we are experiencing nausea, the medications that are chosen are based on an underlying cause. So there are many different causes for nausea. Some of them may be like what we call gastric stasis, so food isn't moving through the digestive tract as easily or quickly as it used to. Sometimes it's medication side effects. Like again, opioids can cause nausea. Some chemotherapy medications can cause nausea, things like that. And then sometimes swelling, either in the GI tract or in the brain. If somebody has like brain metastases or something like that, can cause nausea and vomiting in that patient. So we choose our medications based on what we think is the cause. And some of the common medications you might see, I won't go in super into it, but some of the common medications you might see will be metoclopramide, which is also known as Maxaran. You may see Gravol. You may see ondansetron, also known as Zofran, and then you might see dexamethasone, which is a corticosteroid, and that will help with that swelling and inflammation if we think that that's the cause. Yeah, and if, oh, yep.
I thought that there was recently some words against gravel. Is that so?
In what way?
Well, is it true that gravel can have a bad effect if you take too much?
Gravol is known to cause drowsiness, and that drowsiness tends to increase the higher the dose that you give. But I haven't heard anything apart from that as of yet.
Oh.
I only know of the drowsiness, but if other things are being said, then I'll have to look into it. But I haven't heard anything other than the drowsiness yet.
Okay.
I will say that we like to use Maxaran more than Gravol because Maxaran hits more receptors than Gravol does. So there's a higher chance that it'll help resolve the nausea. And then it has less of a drowsiness side effect as well. So
Lisa, did you have a question?
Yes, thank you. Thank you very much. I was just wondering, so taking any sort of medication, whether it be pain medication or other, is that something that would be discussed with the representative, the legal representative of the patient? And also, am I allowed to ask for like the medical records, like the daily logs for my mom?
that one you're going to have to go through. I'm sorry, I don't know where your mom is, but whatever site she's at, that would be a question for the manager or the kind of nursing team lead there for the medical record piece at least. Again, in an ideal world, putting people on medications, especially something like opioids, would go through the substitute decision maker as well, in my opinion. But for the medical record part, I would probably ask your site specifically, because yeah, each one's going to have a different process for releasing those things.
Yeah, I know you guys don't even need to know that stuff. Can you send us a PFD of all your slides?
Yes, I can.
Thank you.
Yeah. If you want to send, or even just put in the chat the email that you would like it sent to, then I can forward it along after I'm done for sure. Moving on to shortness of breath. So this is just a little kind of clinical model to just show that there are many different factors that might increase shortness of breath. So there's the breathing, so this will be inefficient breathing or increased work of breathing, or like a use of accessory muscles or an increased respiratory rate, kind of those common and more classic signs of breathlessness that can feed into breathlessness. And then we have the thinking aspect, which is thoughts about dying, anxiety, distress, feelings of panic, which can also feed into the breathlessness. And then we have the functioning, which is reduced activity, needing more help from others, and then just general deconditioning of kind of those breathing muscles. And those three things together can kind of turn into this vicious cycle of increased shortness of breath and increased feelings of breathlessness for these patients. So there's just a couple different aspects to consider when we're treating shortness of breath. Some of the interventions that we can use, these are again the non-medication interventions first. Positioning can be huge, so sitting the patient upright and using a pillow for support, stabilizing the rib cage and leaning on a table when standing. Those are all things that can help alleviate dyspnea, as well as if they are in a hospital bed, which they likely are in a long-term care home, elevating the head of the bed to 15 to 45 degrees can help just kind of with that expansion of the rib cage. And being able to kind of take in that breath, giving enough space in the body cavity to allow for that breath, and that can help relieve some breathlessness for sure. Support, so bringing in multidisciplinary team members as needed. The supportive presence of a loved one, of course, is going to be very helpful, but also leaning on an occupational therapist or physiotherapist for equipment. If they need things like walking aids because they get short of breath over longer distances, if they need oxygen, if they need things like that, then bringing in the appropriate team members to help with that is going to be very important. And then the environment can play a huge factor as well. So maintaining a calm environment. So again, we're not feeding into that anxiety circle of the breathlessness. Humidifying the air and keeping it free of irritants and triggers. And then equipment. I already mentioned kind of oxygen and walking aids, and then fans are also going to be incredibly helpful for shortness of breath. Having a fan just blow cool air on the face can be really, really beneficial to that feeling of shortness of breath and can help the patients feel like they can take in those kind of fuller breaths of air. So a fan and clear air can do wonders for these patients. Also, not theories, but I'm blanking on the word, my apologies. But things like activity pacing to conserve energy, keeping conversations short and sweet, kind of going in bursts and then taking rest periods can also be really beneficial for maintaining a level of control over shortness of breath. And then there's also breathing techniques such as pursed lip breathing. So pursing your lips as you breathe can help get in a bit more air. And then doing things like counting, like you're going to inhale for 5 seconds and exhale for 3 seconds, or things like that. If patients are getting very, very short of breath or very heightened, can all be very helpful. When the breathlessness is not being helped by any of those things or not being helped enough by those things, there are medications as well that we can give for shortness of breath. Again, opioids can be used for shortness of breath. And again, they're going to be given in the same principles as if they were for pain, possibly in even less doses. If they're being used only for shortness of breath and not pain, like even smaller doses. Opioids are known to cause like a central relaxation effect on the body, and they're also known to kind of hit some of the receptors in the brain that tell you that you're feeling short of breath, that you're feeling breathless. So they can really help the perception of that breathlessness decrease. It's not going to necessarily solve the breathlessness, but it's going to provide a lot of comfort in terms of the breathlessness. Bronchodilators, if you have asthma or COPD, are going to be standard treatment for those things, as well as corticosteroids might be helpful in certain situations. If you are having like a flare up of your COPD, Sometimes steroids can be prescribed, or if you have a cancer and there is a tumor burden in the lungs or near the trachea or things like that, corticosteroids can help reduce the inflammation and the swelling around that tumor, which will hopefully, again, help decrease the sensation of breathlessness. And then we have anti-anxiety medication, again, filling out, working on that anxiety circle from that first slide. Things like Ativan, like and benzodiazepines can be really helpful for these patients, as the symptom of breathlessness often comes with quite a bit of anxiety. So those can be utilized as well. What about oxygen? This is a question that I get a lot of the time as well. So oxygen is often not indicated unless the patient is known to have low oxygen levels. We can apply it for patient comfort, because these patients will feel like they need more oxygen than they maybe are taking in. So we can apply it for patient comfort. However, if there's no benefit seen within the first 72 hours, it's best to discontinue it, because sometimes giving oxygen can actually push patients in the wrong direction and reduce their actual respiratory drive. I won't get into it, but sometimes it can do a little bit more harm than good if the patient isn't actually having low oxygen levels that need to be corrected. Shortness of breath is not always caused by low oxygen levels, so oxygen might not improve it. And then again, like I said, fresh air via a fan and postural changes, and then medications such as the opioids may be more beneficial for these patients instead of oxygen at that point. If they do have low oxygen levels, then applying oxygen very well may help with their breathlessness, absolutely. But a lot of the times, if patients are nearing end of life and they're starting to feel breathless, we'll put that oxygen probe on and we'll find that their oxygen level is quite good. They just still have that sensation of breathlessness, and oxygen might not be as helpful in that case. Some of the other kind of generalized just changes as patients near end of life, they're going to have a change in appetite. They might eat very little. They may feel unable to eat or not be interested in food. They may only intake sips of fluid. And a lot of the times at end of life, they may develop difficulties swallowing. Yeah, so as their disease progresses and they become close to the end of life, their intake will naturally decrease and they might not be interested like they used to be in food. And while this is probably not going to be painful for the person, it can be really worrisome for caregivers or family members. And a lot of the times there comes a lot of concern around calorie intake or dehydration or things like that. And it's a really natural response for caregivers and families and loved ones to want to continue nourishment, trying to get these people, their loved ones, to eat as much as they can and drink as much as they can. But it's important to remember that most people nearing end of life, they don't experience thirst and hunger as much as they used to, or as much as you and I would. And at the same time as their body systems may be slowing down, not even shutting down at this point, but even just slowing down. Their body may not be able to process food and fluids in the same way. And they might feel like the food is kind of sitting in their stomach, or they might not feel hungry because the food hasn't been processed yet. Or their body just might not be giving them the cues anymore that they're hungry and that they are thirsty, because those systems are kind of starting to shut down and things aren't being processed as fast. So it's important at this stage to only give what the patient wants to eat and what they can safely manage. They might need a reminder to swallow their food or their medications, and it's going to be really important, especially as difficulties swallowing come on, to do mouth care before and after eating, and then just making sure that you're offering kind of small amounts of food and fluids, and just making sure that there's no difficulty swallowing as they kind of move through the disease process. At this point, it might also be a good time to do a medication review and discontinue any non-essential medications, such as like cholesterol medications, BP meds, or like oral hypoglycemics like metformin, things like that, because their intake is not what it used to be, and therefore their sugars and their kind of fluid levels aren't going to be what they used to be. So this is, if patients are really declining and they have these kind of drastic changes in appetite, might be a good time to do a medication review as well. And then any medications that are needed for like symptom management, this is more so end of life. Sorry, I'm getting ahead of myself. But at end of life, if medications are being needed, most of the medications that we give can also be given through the skin or what's called the subcutaneous route. And then changes in strength. So they're going to tire more easily, probably need to take naps more. They might have some exhaustion with routine activities. They might need help with all activities of daily living. They might be very weak and need to be cared for in the bed or on a couch, sitting down. They might become short of breath with activities, and they may lose control of bowels and bladder. These changes can be really gradual, but as kind of end of life nears, they may occur at a more rapid pace. And as the person gets weaker, they may have to change the way they do things, and they may need help doing things that they haven't needed help doing before. So just to remember, this is normal and expected, even in things like old age. And then just leaning on your team as much as you can for things like equipment needs. If they suddenly need a walker or a raised toilet seat or things like that, those are all kind of normal expected equipment needs and changes. And just making sure to reach out if you feel like those things are necessary or needed. A lot of the times the care team is very well versed in these things, and they're able to anticipate those needs and get them in there before it becomes an issue, in my experience at least. So, okay. Does anybody have any questions before I continue?
Just a quick question. I'm just wondering, so with the loss of appetite, what is the parameters of, like, would you give somebody IV if they're unable to eat? Or would we just allow them to, like, just go softly? Like, I'm just wondering what we do about that.
Do you mean like IV fluids or like IV like nutrition?
Yeah, nutrition.
Nutrition. Okay. So that's called TPN. It's called total parenteral nutrition. If it's through an IV, and then if it's through like a nasogastric tube or like a different kind of feeding tube, then that's called enteral feeds. And they're a little bit different. TPN is often only given for patients with a very high functional status because it's a very specialized kind of thing. So a lot of the times before they would go to TPN, especially in your case with dementia being kind of the main diagnosis, it would probably be less of a TPN conversation and more of like an enteral feeds conversation. So like a feeding tube. And that is kind of one of the golden questions in palliative care is like, aren't they going to starve to death? Shouldn't we be feeding them? Can we put in a feeding tube? Things like that. And what's the most important to consider in that case, and it's going to be so drastically different for every case. So again, this is like a really, really general overview. But again, the most important thing is going to be looking at that patient's quality of life and what their goals of care are. If giving them nutrition will allow them to continue living life in a meaningful way to them and enhance their quality of life, then it can be considered. However, if patients are nearing end of life and they're getting to this point where they're no longer wanting to eat or drink, a lot of the times providing that nutrition won't necessarily increase that quality of life for them. Again, each case is going to be so different, very general. But yeah, it's looking at, are we going in the long run for this patient and within what we think we know this patient would want, will providing this enhance their quality of life is going to be the main question. So I can't really provide like a hard and fast answer on that one. There aren't really any parameters to say like yes or no to those things, at least not that I'm aware of personally. It's all about looking at the specific patient situation and asking, is this best for that patient? Yeah, okay. Okay, so moving on to like end of life. So this will be the like last hours, days to weeks of life. Again, we're going to be talking kind of more directly about death and dying. So if anybody needs to leave the room for a moment, please feel free to do so. But as death approaches, the changes at this stage are going to vary wildly. There is no blueprint for dying. Yes, our bodies kind of know what to do, but each body knows what to do a little bit differently than the other. Some patients, and especially depending on their disease process as well, like somebody who is passing away due to dementia-related causes may have a very different death than somebody who is passing away due to heart failure or cancer or things like that. So changes at this stage can vary quite wildly. These changes can be really difficult for families and caregivers to watch, and understanding what's happening and what you can do in those situations might be helpful in alleviating stress and worry, which is my goal for going over these kind of symptoms and changes as we move along. So there might be some changes in level of awareness. So they might become restless, excited, or irritable. They might have some personality changes that you maybe weren't expecting. They might be easily distracted or maybe unable to follow simple directions. They might seem a little bit drowsy. They might have a short attention span, or they may even seem confused near end of life. And they may seem to suddenly become quite forgetful as well. These are all kind of, again, I don't want to say normal, but they are common symptoms at end of life as kind of systems shut down. And if there is a previous diagnosis of like a memory disorder or a dementia, then those sort of symptoms can also become worse near end of life. So encouraging family and for yourselves to save important conversations for periods of wakefulness, knowing that these periods might fluctuate throughout the day. And then keeping visiting times brief and encouraging visitors to sit quietly at the bedside might be really beneficial to keeping kind of a calm environment for these patients, and just not confusing, adding in any more confusion or agitation kind of to the mix. Yeah, just saving those important conversations for when there's a lot of lucidity and alertness, and keeping those more confused, more drowsy times as calm as possible is kind of my advice for this symptom. They might have some changes in their skin. They might have cool hands and feet. Their extremities, so like their legs or their arms, may appear mottled or blue or purplish. And there might also be skin breakdown. We try our best to prevent skin breakdown, especially in palliative patients. That's why we are hopefully repositioning them often, whether that's rolling to their side or propping them up with a pillow or things like that. But as that circulation, especially to those extremities and those pressure points, kind of decreases, there might be some skin breakdown that happens. Or there might be wounds from previous, like there might be previous wounds from before they were bedbound or at end of life. And often at this point, wounds are not considered to be healable because the patient is often not taking in a lot of nutrition to help with that wound management. And there is also often decreased circulation, so less blood flow to those areas to help facilitate that healing. So at this time, the focus again often shifts from curing and treating to more comfort. So we often use kind of like cushioned bandages to provide as much comfort as we can. And then we just try and do our best to manage any of the odors or any of the drainage from the wounds. While they may feel cool to the touch, the patient themselves often won't actually feel cool, and continuing with normal blankets and coverings are normally sufficient to keeping them comfortable. You might notice some changes in breathing. They might have irregular or shallow breathing. You may notice that they're using their chest, neck, or upper abdominal muscles to assist with breathing as their general muscle tone kind of decreases. Some of their what we call accessory muscles need to kick in to help with the breathing. They might have short intervals of not breathing. This is also known as apneic spells. And these spells may be up to a minute in length, and they might get longer and occur more frequently the closer to death a person gets. And then their breathing may be deep and rapid or slow with pauses. Again, each person is going to go through this process differently. Some people may have apneic spells before they pass, some people won't. Some people will have irregular shallow breathing. Some people will have deep and regular breathing. It kind of just depends on the person. Sometimes breathing changes, especially if it's accompanied by other signs like facial grimacing or things like restlessness. Sometimes changes in breathing can indicate discomfort, but a lot of the times just the natural passing process will also bring some changes in breathing. So it's just good to be kind of aware of both. If you're ever worried about discomfort in your loved one as they're nearing end of life, just raise those concerns to the nursing staff as soon as you can, and they can do kind of a thorough assessment and see if anything needs to be done. But just knowing that changes in breathing are normal and are kind of likely to occur. Respiratory congestion. This used to be called the death rattle. We do not like to use that term anymore for, I think, probably obvious reasons. It's not the nicest term, but it's the term that people are, I find, still most familiar with, so I do like to still mention it. But right now we like to say respiratory congestion. It's a little bit nicer. But these are secretions in the throat, and it makes their breathing sound wet or congested. So the secretions, a lot of the times they're what we call upper airway secretions. So they're kind of sitting in the upper airway. And as the air is moving in and out, as the patient breathes, it's making these kind of waves over the secretions, this kind of like turbulent kind of noise. And that's what causes that kind of rattling sound as they breathe. There are lower secretions as well, but those are kind of less common. Those are caused more by like fluid on the lungs and are most often caused by something that happened prior to the end of life, something like an infection or like a pleural effusion, which is like water around the lungs, things like that. So the more common one is the upper airway, and that's when as patients near end of life, they aren't able to swallow or safely clear the secretions that their body is making, whether it's saliva or like other throat secretions. So they kind of get trapped in the back of the throat a little bit. It's a very common symptom at end of life, especially in the last 24 to 48 hours. And a lot of the times the patient is their level of consciousness has decreased because their body systems are shutting down and they're nearing end of life. And the patient's often not even aware that they're making those noises or that they have those secretions there. There are medications that we can give to try and help with the respiratory congestion. These are called anticholinergics, and their main kind of role is to help dry out secretions. The thing is that they cannot dry up secretions that are already there. They can help prevent the production of more, but they can't really dry up what's already there. And if they do, we could run into the problem of those secretions now becoming even more thick and sticky and even more difficult for that patient to clear. So what we suggest is you can try the anticholinergics and see if it helps. However, if we're not seeing any benefit, we do recommend to stop giving them, as if there is no benefit in the first couple of doses, there likely will not be a benefit moving forward. A lot of the times, both families and nursing staff like the care team, will give these medications just to feel like they're doing something for it. However, respiratory congestion is kind of just one of those symptoms where medications don't always do the trick. So if it's not working, it's better to stop it. What does work for respiratory congestion, or what can work for respiratory congestion, is repositioning the patient, so rolling them on their side or raising the head of the bed can help clear the secretions. Or if we roll the patient, sometimes the secretions will pool in the cheek, and then we're able, or in the kind of back of the throat where you can kind of see it better, and then we're able to gently either swab it or suction it out. A lot of the times with this too, nursing and family members will ask for suction to try and get the secretions out. But a lot of the times the secretions are actually too far down for us to safely suction, and putting that suction catheter all the way into the back of the throat can actually be more distressing to the patient than the congestion is. So unless we can see the secretions in the mouth and can easily grab them, we don't really recommend suction either. It might seem a little bit counterintuitive, but they're just really not in a place that's easily suctionable, and it can be quite distressing for the patient to have like a vacuum stuck in their mouth, if that makes sense. Okay. So the last one I'll talk about is restlessness. So sometimes people can seem confused, or they might be hallucinating. So like seeing, hearing, feeling things that aren't present as they near end of life. They can seem to be experiencing a different reality from ours, and this reality can either be comforting or it might be very scary for the person. So I would just encourage you guys as the support people to talk about what the person is experiencing, listen carefully, and gently ask questions as able. They might be unable to recognize familiar people or surroundings. They might be restless, excited, or irritable for no apparent reason. They just don't seem like themselves. And especially nearing end of life, like in the final 24 to 48 hours, they might be quite restless in the bed, calling out, moving their limbs quite a bit, things like that. Again, I don't want to say it's normal, but it is a common symptom and something that we should be aware that might happen. So with this end of life restlessness, and with any really like confusion, things like that in general, it's always best to come at it from a non-medication approach first, especially if it's more of a mild kind of delirium or restlessness. Just providing a calm environment, talking in low tones, providing familiar faces as able. Kind of if your loved one has like a dementia or another memory related kind of illness, just keeping with those same principles of meeting them where they're at, and not trying to maybe break them out of this reality, but instead kind of joining them in it. However, if the restlessness is moderate to severe, so it's distressing for the patient, they are like trying to crawl out of bed when it's really not safe for them, they are lashing out and are maybe a danger to themselves and others, or they're just like they're just not comfortable. It doesn't look comfortable for them. There are medications that we can give that can help with this end of life restlessness. Some of the ones you might see are called haloperidol or Nazanan, and those are medications that kind of have a sedating property that can help ease the restlessness and make that patient comfortable as they near end of life. Again, those medications are only really reserved for those moderate to severe cases and should only be used after the non-pharmacological has been tried. So the distraction, relaxation, keeping a calm environment, familiar presence. If those things aren't working, then we can move to those other medications. We'll also look to look at if there's anything else that might be causing the restlessness. So if we're seeing signs of pain, then we can administer the pain medication. If we're seeing signs of like breathlessness, then we can administer medications for that, because they might be feeding into the restlessness. And maybe perhaps making them comfortable that way will decrease the restlessness. Again, I'm trying to give a very general overview. Each case is going to be so different. But just knowing that it's something that might happen, there are things that you guys can do as the caregivers, and then there are things that we can do as a healthcare team to make sure that the patient is comfortable at end of life. And then, yeah, so the moment of death, no matter how much you prepare, no matter how many symptoms have been explained, or medications have been explained, or how many people come into the room and talk to you, there really is no way to truly prepare for a loved one's passing. And the patient's passing will occur in its own time and in its own way. The experience will be different for each patient and for each family member. And despite knowing it was coming, families are still often quite shocked at the time of death. So at that time, it's important to just allow the staff to guide you with what is needed in terms of next steps, and then take as much time as you need to say goodbye. I know the few times that I've attended deaths in long-term care, I find that family members quite often immediately turn to like, who's going to call the funeral home and who's going to pick up the body and when are we supposed to take their things out of the room and all of this sort of a thing, that sort of thing, sorry. So it's just really important to, if you have those questions, allow the staff to guide you with kind of what the next steps are. Each home will have their own kind of protocol and guide and way of doing things. So just really leaning on them. And then also just making sure to take as much time as you need, regardless of those kind of next steps sort of a thing. Just remembering to take that time to say a proper goodbye and allow yourself to kind of be in that moment as well. But that is the end of my presentation. And now I have time for questions if anybody has them.
It would be good to take, to have a paper copy. Is there such a thing?
Yeah,
Of all your
if anybody is able, maybe just the people running the family councils, if they would be willing to reach out to my email, or even just put their email in the chat of this Teams message, then I can distribute the PDF of the slides to each family council, or to whoever would want them.
Thank you very much, Amy. Very informative. Oh, it looks like Vera's got a question. You're on mute, Vera.
How's that?
That's better.
There you go.
Amy, I'd just like to ask you, you mentioned lucidity just for a second there. Near the end of life, is lucidity does it happen more often? And the reason I ask this is because my mom is 99. She's very healthy, but she's just old.
Yeah.
And she doesn't have medication. She has one medication only for high blood pressure. But in the last, about 3 years ago, I had the most, she has dementia, but she was so lucid for a full day. And it was just like having her 65-year-old back in your, but now in the last 4 or 5 months, it's been 4 times now that she's just like right on top of things, but it doesn't last for very long.
Yeah. Honestly, it's really patient specific. Unfortunately, it's really hard to say. I would probably say the opposite, that lucidity tends to decrease near end of life, but I will say there is a phenomenon that is kind of well known, and it's called the rally. So that's when a patient who is in the last days of life, they have like one good day where they're like really energetic, they're really lucid, they're really on top of things, and everybody is so, it's unfortunate because everybody becomes so very hopeful that their loved one is getting better and increasing and doing these things, but a lot of the times that the next day they are even worse than they were. Nobody really knows how to explain the rally or what causes it, but that is a well-known phenomenon as well.
Yeah, thank you.
Okay, I've got your email addresses that were put in the chat. And if I recorded this properly, I'm new to all this too, so hopefully I didn't mess up. And I will send the video on to anybody who wants it.
Sounds good. Yep. Okay, so I'm seeing some people log out and I'm not seeing any more questions. So I think that I'll leave it here. Rita, you said you had the emails?
Yes, I've just copied them all here.
Okay,
Yes.
perfect. I can't see anything in the chat, so I might reach out to you quite quickly after this just to make sure I send along that that file to you. Thank you guys all so much for attending this presentation. It's been lovely to see all of your faces and meet you all. And thank you so much for Rita for organizing.
Yeah, thank you again, Amy.
Yes, of
Thank you.
course.
Thank you both very much.
All right, you guys have a lovely rest of your afternoon. Hopefully there's some sun coming our way. I hope.
Bye-bye.
But bye-bye.